So my name's Dr. Modi, Vikash Modi. I'm a primary care doctor by training, family medicine. I've been here in the Atlanta market for the last 15 years, practicing mostly in the preventative medicine space. So I've been working with a large healthcare group called Piedmont Healthcare, developing their internal programs. And I've worked with a couple of private groups like Live On Health Center and now Prenuvo, developing, again, more proactive approaches to healthcare. Now, Prenuvo is sort of like a really wonderful option because they're already doing such an interesting thing with these whole body MRI scans, which to me was already sort of a foreign thing when I first met them a couple of years ago. The idea of doing a full body MRI was not evidence-based. There was no guidelines or research, that was really published around it. So to me, it felt like, okay, where is this coming from? What's the goal here? And then I started seeing some reports. My initial reaction was, oh my God, that's so much data. What am I going to do with all this? But when I sort of leaned into it and started to really dissect what the information is showing me, what it's not showing me, I was able to actually tease out quite a bit when it comes to the world of proactive and personalized healthcare. So I'm very happy to say that the Prenuvo scan became almost a regular part or a daily part of my routine, that I would see maybe 5 or 6 patients a day in my personal clinic, and we would be getting Prenuvo scans or whole body MRI scans, and we would just see these like really excellent integrations of their blood work, of their histories, of their symptoms, match that with the MRI results, and I can now accelerate or give them such an advanced personalized treatment plan. It felt like it was light years ahead of what I'd been doing before. So we've taken the idea of like an annual physical or an annual checkup and now accelerated it to this really like in-depth visualization of the body. And again, we're seeing here things in the world of tumors and growths and that really interesting ability to kind of detect diseases early. But we're also seeing very kind of like, I don't know, to me, it's the exciting stuff, but to a lot of people, it's the boring stuff of like degenerative spine disease, fatty liver diseases, any signs of increased visceral fat and adiposity that isn't very obvious from their outside BMI evaluations. So I started to get really, I nerded out. I'll just be honest. I nerded out over what I was able to learn and interpret from these scans. And so that's what I'm going to do now with you guys, is start to show you how we incorporate some of these things into our regular practice. I just came off of a consult with a man in Singapore that we did the scan on. And he's a health hacker, bio-longevity guy, but he's got terribly high cholesterol. And so we focus on things like, does he have any fatty liver? No, but he does have an excess of visceral fat in his MRI scan, which is not very apparent from the outside. So I was able to kind of lean into the idea that maybe he needs to make some nutritional adjustments and some modifications to his exercise and start to target this visceral fat. We even went so far as to talk about a GLP-1 medication, because from the outside, his BMI is only 25.8. So he doesn't meet criteria for a GLP-1, but he's got extremely high cholesterol. He's got an A1C of 5.8 with insulin resistance, and he's got an excess of visceral fat. He's in like the 70th percentile for visceral fat. So to me, he's actually an excellent candidate for a GLP-1, and that's where I'm sort of leading him now with our consultation. We're going to start with just the premise of the MRI, look at the unique aspects for the Prenuvo scan, and then we'll talk about that patient and provider experience. Because again, this is not just the patient experience. This is also how this affects your practice as a provider. So some basics about the whole body MRI that I'd like to share with you. Right now, our scan time for a head down to the ankles is about 45 to 50 minutes. 45 minutes for a female, about 55 minutes for a male. And this is diagnostic quality, meaning that we're getting really high value images here of the body. Now, that being said, we're not a dedicated MRI, a diagnostic MRI. We're not using contrast, which is both a good and a bad thing, right? So, when we talk about sort of like these high quality value images, I don't want people to get sort of the idea that this replaces a diagnostic MRI of the shoulder, or this replaces like a dedicated CT calcium scan of the heart. There are some things that just need to continue to be a diagnostic personalized study. But our scan is like a nice general inspection. It's a see a lot study, but it's not a see everything study. That's how we'll look at it. And I'll dissect that a little bit further when we get into some of the details. It's obviously quality controlled end to end, meaning unlike some of the other whole body MRIs out there, we actually are in possession of this process from top to bottom. When you come to one of our clinics, it's owned by us. It's our personally trained front desk folks. It's our trained scheduling team. It's our app, it's our MRI machine, it's our radiologist, and it's our primary care providers who provide our own consultations. So again, it's a very controlled experience. And I think that really reflects when you come into one of our clinics, when you go through our scan experience, you sort of see how that really matters. As opposed to like going to like other MRI places where, the radiologist is in Texas and the scan is owned by another company here in Florida. I mean, it's just such a different experience when you have this kind of diverse work group. And then the last thing we like to talk about is how this really empowers primary care. It's not taking away, but it's adding to everything that you guys are trying to do. Some quick details that are important to think about. Obviously cancer rates are rising in America. There's only right now 4 organs that have a dedicated scan dedicated to screening for cancer. We all are familiar with those things in the USPSTF guidelines. So at that point, with only 4 organs being routinely tested, only 14% of cancers right now are being detected by those USPSTF guided guidelines. The other 86% are just sort of out there, and we catch them when we catch them. We'll see symptoms, or we'll happen to catch it incidentally on a scan. Our scan lives in that space. We are not trying to replace the dedicated scans, the low-dose CT scan for lung cancer screening. We're not trying to replace mammograms. We're not trying to replace the PSA for prostate cancer screening. But those things still have their unique value in the healthcare space. The whole body MRI is sort of in that other space: pancreatic cancer, gastritis and gastric diseases that may not be perceptible from a basic physical examination. That's where the whole body MRI needs to live in your brain. And then again, this last thing here is the idea of early detection, that right now about 45% of cancers are diagnosed stage 3 or 4. That's a really powerful number, that if only 45 are diagnosed stage 3 or 4, then we're catching these diseases quite late. The numbers at Prenuvo are somewhere around 65% of cancers that we detect are in stage 1 or 2. So we are seeing things earlier on average through a Prenuvo scan than they're being detected out in the real world. These are numbers that, again, we're probably all familiar with. Millions of women suffering with abdominal pain from undiagnosed fibroids. That's something that our scan is very, very excellent at picking up, is uterine fibroids, adenomyosis, as well as ovarian cysts, polycystic ovarian syndrome, fluid in the pelvic cul-de-sac that might indicate endometriosis. So our scan is very, very sensitive for picking up those women's pathologies. Fatty liver. This is one of our bread and butter things, is that we can actually detect and then measure fatty liver from our whole body scan. And we're going to see it. We'll show you guys a case at the end here. We're going to see it before you see it on the transaminases. So as you do your AST, ALT scores and you do your FIB4 scores, you're looking for early signs of steatosis or fibrosis. And we're able to detect those things visually before they'll show up on the blood work, which is a really, really important thing. And then the last couple of things there is just IBS conditions. The idea of women diagnosed with things like endometriosis and infertility issues. We're just able to see those things so clearly and vividly on our MRI. Another fun case recently is that we scanned this woman who's been having pelvic discomfort and irregular menstrual cycles, and we found a 10-centimeter teratoma coming off of her right ovary. Now, when she went for her transvaginal ultrasound for the same thing, they only measured 4 centimeters of what they thought was a simple ovarian cyst. It ended up being something called the tip of the iceberg sign for endometrioma, or for teratoma, which is that the transvaginal ultrasound was only able to detect the first 4 centimeters. It wasn't able to see the other 6 centimeters through a transvaginal ultrasound because of the way that the fat and the teratomatous tissue appears on the ultrasound. So our MRI was actually more sensitive than an ultrasound for that particular condition, and we were able to get that woman quite a bit more help than she was originally getting from her OBGYN. The next slide here is going to show us the idea of chronic degeneration over time. That one of the things that we hope to encourage with our patient population is the idea that this is not just a one and done scan, because it's a nice thing to get a snapshot and say, okay, as of right now, I'm okay. There's nothing major going on. That's great. But we've got to start looking at some of these other metrics of degeneration. I start to look at shoulders and knees and hips, specifically spine. We have a wonderful spine series. And once we can catch their baseline, we can start to make interventions, right? So a mild degenerative arthritis, the pictures always look a little bit worse than the symptoms in the young people. And when we see mild or moderate degenerative arthritis already in a young person in their 30s and their 40s and their 50s, and they might be pre-symptomatic or mildly symptomatic, we can start to really encourage physical therapy, adjustments to posture and ergonomics, changes in weight management, and then strengthening, physical therapy. Let's get that spine even healthier than it is before. We can actually show improvement of spinal degeneration on people's subsequent scans. The flip side is, though, you start to show somebody that they're getting ongoing degeneration over time, and that starts to maybe predict what their pain symptoms are going to start looking like in the next 5 to 10 years. And if you can show them that prediction, you can, again, try and encourage intervention before it becomes fully symptomatic. Here's a quick synopsis of our brain sequences. Our brain sequences include the flare of the brain. So this is where we're going to pick up our nice little tumors and masses in the brain. We also have a really nice vascular evaluation. It's almost it is a circle of Willis time of flight scan. So we get this really beautiful MRA angiogram of the brain, non-contrast, and that's how we pick up our aneurysms down to about 3 millimeter sensitivity. I want to freeze for a second. I just mentioned the size. The whole body MRI is built on an accelerated sequence of images. Our current slice thickness is about 3 millimeters in the brain and 5 millimeters in the body. So starting from the sinuses on down, we're probably about 5 millimeter gap thickness. We have to leave a little bit of gap thickness because otherwise patients will be in the machine for 2 hours or 3 hours getting a full body 1 to 2 millimeter gap thickness. So in the essence of trying to keep the time down, we've accepted 3 millimeters in the brain and 5 millimeters in the body. The reason that we feel comfortable with that is because most pathologies start at those baselines. That once you reach a 3 to 4 millimeter aneurysm of the brain, or a 3 to 4 millimeter cyst of the brain, now we're talking about real pathology that's going to have a major impact to that patient's life. In the body, same idea is that, most things like the thyroid, the lung, we talk about, what is their Fleischner guideline recommendation. Usually that starts around 0.5 centimeters or 5 millimeters before we're really going to start getting excited about anything in the pulmonary region. So that's why we've accepted those slice thicknesses. But that's a really important point to share with your patients before the scan, because if they have a 2 millimeter nodule in their thyroid or a 3 millimeter nodule in their breast, our scan may not detect it. We may not be able to see that because of the slice thicknesses that we're using. So it's really important to tell patients we're not really doing surveillance of those. The Prenuvo scan may capture it if it falls right on that slice thickness, which is a really great thing. When we can capture it, we'll talk about it. Say, yep, we saw that 2 millimeter thing. We saw that 3 millimeter thing in the kidney or the thyroid. We'll talk about everything that we see, but if it happens to fall between our gap thicknesses, it may be almost invisible to our scan. And we don't want patients to get upset or frustrated. Hey, I wanted to see that thyroid nodule. I wanted to see that breast cyst, that liver hemangioma. It's really important that we kind of set that expectation that some of those really small things may not be picked up. We're looking for bigger things. We're looking for growth. Anything over 5 millimeters in the body, 3 millimeters in the brain is what we're trying to detect. And so the rest of these sequences is now what we're adding to our enhanced scan. That's another package that hopefully we'll be able to share with you in San Diego. We're doing it in LA already. Is that in addition to these yellow sequences, now the green sequences have been added in our enhanced scan protocol. So that includes now an ASL, arterial spin labeling of the brain. We can get even more definition of arterial flow. We're looking at SWI, which is susceptibility weighted infusions, so better fidelity on those brain masses. And then we're also getting just higher logistics on the physiological sequences here, which show us how you have any signs of any kind of metabolic dysfunction. Essentially, our new brain scan, which is like a new product on top of the whole body MRI, the enhanced brain scan, is going to show your patients any early signs of cognitive dementia earlier than they might expect to see it otherwise. So we can start to see loss of brain volume, changes in blood flow, circulation, much earlier than they might be symptomatically or seen on a regular routine scan. And that's just like a really brilliant thing for us. We're using artificial intelligence to help us map out the brain and plot out what the brain volumes look like in each individual segment. And we can start mapping that out over time and saying, hey, we're seeing a rapid decline in your temporal lobe or rapid decline in your hippocampus. This is now a predictor for ultimate cognitive decline. We need to make some interventions now. What kind of interventions are we talking about? This is where I'll start to explore the idea of sleep apnea even more. Someone who's been snoring for years but hasn't really dealt with it. This is a major outcome of uncontrolled sleep apnea. We start to look at their vascular health. This is someone who has high blood pressure, cholesterol, high blood sugar. We haven't really been dealing with it aggressively. This maybe indicates that we need to be much more aggressive with controlling those metabolic risk factors. Obviously, vitamin deficiencies like B12 and folic acid play a role in this. And then ultimately, if they are just sort of heading towards what looks like cognitive decline with loss of brain volumes, we're going to start to talk to the neurologist and see what other interventions we can introduce. Is this somebody who would benefit from early medication treatment options? But at least it gives us a fighting chance of stabilizing these things earlier before the symptoms really become evolved. Now, the unique aspects of the Prenuvo scan, I think, are really important to talk about. So when you send a patient to Prenuvo, what are we going to get there? We've got at least 15 years of practice experience that Prenuvo's actually been doing whole body MRI since the early 2010s. We started up in Vancouver, Canada. Our founding radiologist, Dr. Raja Tariwala, started doing these scans that long ago, and we've sort of evolved the program since then. So we are literally one of the oldest names in whole body MRI. We again operate our own clinics and control the entire experience. And then we've got 10x the number of studies than any other company doing this out there. So our wealth of experience and our wealth of data is what's helping us to make sure that we're kind of on the front edge of what this study can accomplish. The image quality, we are now 3x faster than most hospital grade whole body imaging at about 1/10 of the cost. Doing a scan like this at your regular hospital without diagnostic codes as a preventive scan would cost literally 10 times what we're charging people. So that's really important to think about when we're talking about, why is this, the cost of this scan seems like a lot of money for folks, but when you're really trying to accomplish this amount of data, we're actually at a very low cost point. And then the tissue resolutions, the tissue resolutions here about 10x more lesion discrimination than any other type of scan in the similar space. We've got over 100 board certified radiologists. We have about 40 board certified primary care providers in the world of nurse practitioners and MDs who are delivering the consultations afterwards. Now that's an interesting thing for y'all's team is, once the scan is completed, patients will have an automatic complimentary nurse practitioner or physician consultation from us. That's something that we offer to every patient who comes through. But if your group decides that you want to take those consultations yourselves, we're more than happy to just let that be the first point of contact after the scan is completed. We'll release the report to your team. You and your patients will have that consultation yourselves, and we'll sort of stay out of the way. So you have it both ways. You can have it personalized, or you can have it complimentary through us, but we're happy to always assist that process. Here's what one of our clinics looks like. If no one's had a chance to visit one, they're usually a very pretty location. I'm in our Atlanta clinic right now. I don't know how much you guys can see there, but our clinics are very, very sort of spa-like. When I first came to visit a Prenuvo location, I was like, what is this place? This doesn't feel like a healthcare facility. But that's something that our patients have come to love, is that getting like an imaging test can often feel like going to the DMV and you're sitting in line in a crowded waiting room, and it's a very impersonal experience. With Prenuvo, you come in, you've got a personalized concierge person at the front desk. There's usually not more than 1 or 2 people sort of waiting at any given time. Depends on how many magnets and scans we're running that day. But like in Atlanta, 1 magnet means 1 person per hour coming through. So you're not sort of overwhelmed with other people around you. And then of course we have our little snack bar and coffee for after the scan's over. And you have your own personalized waiting room and changing room with your scrubs that you put on. Leave your clothes in there. You lock the door with your own thumbprint as a patient, and that way everything just feels a lot more sort of high level for your experience. So I'm happy to say that our in-clinic experience is the highest NPS scores that we've got. Here's what our machines look like. These are pretty standard. This is a Philips magnet in particular. All of our MRIs are either Philips or Siemens. We run 1.5 Tesla coils everywhere. So if you're familiar with MRIs, you can kind of think about 1.5 or 3 Tesla. They go up to 7 and 10 Teslas. What happens though is once you get to 10 Teslas, you can't come within like a 10-block radius without something magnetic happening. So we don't do 10 Teslas. 1.5 versus 3 Tesla is the real debate. We've optioned to 1.5 Teslas because that level of magnetic imaging gives us an ability to control the sort of noise ratio. So that's a really important thing. At 3 Teslas, we have an ability to overdiagnose or over-visualize a lot of noise within the soft tissues. And so our fidelity or our sensitivities start to go up, but our specificities start to go down. And so we've landed on 1.5 Tesla quite purposefully because we're able to maintain a pretty good sensitivity and specificity at that level. We reduce the sort of side noise that comes out of those soft tissues, and we increase the fidelity of the hard tumors that we detect. The other nice thing about our MRIs, again, if you've never had a chance, I would encourage you guys to have the experience of a whole body MRI. It's a very nice bed. There's like comfort cooled mattresses. We put coils over the whole body, including the face, which can feel quite claustrophobic for your patients, so please prepare them for that. But we also employ a series of mirrors and a TV screen behind the magnet so that people can literally sit there and watch television on YouTube or Netflix. They're able to watch something while they're in the machine. They have noise-controlled headphones and earplugs. And so the experience is very, very relaxing for most of our patients. It's not your traditional MRI with the loud noise. Yes, we have that noise, but the patients don't perceive that. All they're doing is sort of watching their favorite show on TV or listening to their favorite podcast on Spotify. and then they're hearing the technologist's voice when it's time for breath holds. Otherwise, a lot of our patients just fall asleep in there, which is quite remarkable. To be in the machine for 45 minutes and feel completely relaxed is a very different experience for a lot of patients. A nice statistic to share is that nationally, we're somewhere around 10 to 15% of claustrophobia, which causes cessation of MRI scans. So again, nationally across all imaging centers, not Prenuvo, the rate is about 10 to 15% of studies that have to be suspended because of anxiety or claustrophobia. Prenuvo's rate is about 1%. We have a 1% claustrophobia rate, and that's really a testament to how our entire process feels much more relaxed for the patients. Here's a quick map of our locations right now. So again, here on the West Coast, we're seeing San Diego, Irvine, LA, and now Redwood City. Sorry, Redwood City came first, actually. We're now scattered all over the East Coast as well, and then we've got now a number of outposts in the Midwest. So the idea here to share is that if your patients are traveling, they can actually maybe schedule their scan in other places. So if they're coming to you from other cities, we can arrange their Prenuvo scan in their home city. If they are traveling from their home city out east or out west somewhere, they can maybe get the scan done as part of their travel. So it's all about availability for us. And we like to think that the more locations means more availability, easier access for all of your patients. And then, sorry, just a quick note, you'll notice here our international footprint is also growing. So now we're getting into Europe, the Middle East as well. And I think we've got some eyes out east with Singapore and Sydney. So this is what our standard protocols look like. I'm not a radiologist, so these pictures look great to me, okay? When we show this to a radiologist, though, they're blown away by the value of these images. So I'm always getting remarks from physicians and radiologists who say, wow, I didn't expect the image to be so good. I just did a consultation personally for a man who trained at Johns Hopkins in radiology, and he said, I was actually blown away by the sequences and by the value of the images that you guys collected. In 45 minutes, he was absolutely floored that this is what we were able to show him. The bread and butter scan for us is the whole body DWI. That's diffusion weighted imaging. Diffusion weighted imaging is a sequence that's usually reserved for breast and prostate tissue. We're actually applying the DWI sequence to the entire body, and that's why it ends up functioning like a PET scan. Whoops. So DWI helps pick up any solid tumors by detecting any free diffusibility of water within the soft tissues. So basically that means that hard tissues or tumors light up like a Christmas tree in our DWI scan. So again, something that's usually reserved for breast tissue or prostate tissue, we're applying to the entire body, which is why we're able to detect especially things in the abdominal cavity so early. Some of the conditions that I like to remind people that we can really do a great job with is white matter diseases like multiple sclerosis detection, benign and malignant brain tumors. I'm sorry to say, I can't tell you how many brain tumors we've picked up in the last couple of weeks here. I was just on the phone with a woman yesterday who we found a 3.3 centimeter mass in her right frontotemporal lobe, pre-symptomatic, asymptomatic. It looks like a stage 1 glioma. So we're able to now get her out to her primary care doctor, get her referred. She already has a referral to neurosurgery through her primary care. We're just accelerating now the treatment plans, and she's going to be able to get this thing evaluated months, maybe even years before it became catastrophic for her. Cardiovascular diseases like aortic and brain aneurysms are very easily detectable through our current sequences. What you're missing here is coronary plaque, arterial plaque disease. Plaque is not detectable on a non-contrast MRI for us. So our current sequences do not allow us, and that's most MRIs without contrast, are not going to be able to detect carotid artery plaque or coronary arterial plaque. So please make sure you're still referring people for those types of independent studies if they have those risk factors. Metabolic diseases like fatty liver and hemochromatosis are very easily detectable, and we even measure those things and give people measurements. The lung masses and tumors, pancreatic and stomach diseases and gallstones are very visible for us. Urinary bladder cancers. In the limbs of women's health, we talk about fibroids and adenomyosis. In men's health, prostate cancers and prostate enlargement. We measure every prostate gland for every male patient. So you'll get a volumetric assessment. Your prostate volume was 25 milliliters. 30 is our typical cutoff to be considered normal. That's great. Or you have like a prostate gland that's 58 milliliters. This patient very clearly has BPH. let's get more aggressive about treating that if they are symptomatic at all. And a lot of patients are kind of holding back. Yeah, I wake up 2 or 3 times at night to pee, doc, but I just kind of go right back to sleep. That's a quality of life thing that we like to talk about with our patients. And then the musculoskeletal system, we can really see signs of inflammation around the joints. Bone lesions and bone cysts are easily visible. Sarcomas and bone tumors are very, very detectable on our scans. Some good statistics for us are that we have alerted about 1 in 20 patients on average for a life-saving diagnosis. So that's a real number, that out of 20 random patients who come in, pre-symptomatic, asymptomatic, 1 out of 20 is going to walk out of here with a life-changing diagnosis. And again, I'm fortunate here in the Atlanta clinic to get to see those firsthand. We're picking up brain tumors, liver masses, significant aneurysms. And I usually, when we catch them on the bed, we send them straight across the street to the ER. And the ER now got to know us, and they know anything that Prenuvo sends over, go ahead and advance that to a level 1. That's a pretty serious finding. And then, a fun statistic, I say we like to assist 100% of our patients with life-changing and insights. So again, every patient is going to walk away not saying everything's fine, see you later. Here are the 5 or 10 things. Here are the 2 or 3 things that we're really going to focus on this year based off of the scan. So it gives you and your patients a little bit of a roadmap. Here are some projects I want to start to encourage with you. We're going to work on spinal health, joint health. We're going to look at visceral fat or fatty liver diseases. It really gives you and your patients a leg up and start to feel a lot more engaged and proactive about your healthcare. For whole body MRI, there is a scale called the ONCO-RADS scoring system. So again, you're familiar with PI-RADS, LI-RADS, BI-RADS for breast. ONCO-RADS refers to whole body MRIs. This is actually a scale that our radiologists helped develop. So Dr. Raj Atariwala, who I told you was a founding radiologist, he's actually one of the co-authors on this paper. So we developed this scoring system to help identify low risk versus high risk results. This is specifically for cancer results. So now when you get a MRI report from Prenuvo, you're going to get an ONCO-RADS score associated. A score 1 through 3 is very typically low risk. A score of 4 or 5 is very typically high risk. So anything that's in the 4 or 5 category is very highly suspicious for malignancy or cancer. That's what we're going to typically call like a life-saving catch, right? So that's the 4 or 5 ONCO-RADS. Now, similarly, I don't think I have a slide on this one yet, but we're now developing a second type of report, a second type of scan called the terrible writing, CSD. That's clinically significant diagnosis. That's a separate scale that's on a similar sort of regimen as ONCO-RADS that we're now developing. We're going to hopefully publish a paper on that in the next year. This clinically significant diagnoses means anything that's non-oncological can also be detected. So what does that mean? Something like a brain aneurysm, something like a large breast mass, or something like a large liver mass that looks dangerous, that might be causing like a rupture, splenic aneurysms. Those are CSD criteria 5. And those are, again, something that we would consider something life-saving. So again, a CSD 4 or 5 or an ONCO-RADS 4 or 5 gets grouped into these sort of 1 in 20 life-saving catches that we find. Again, some things that we don't catch, really review this with your patients if they're looking for tendons and ligaments and cartilage injuries. We're not being able to diagnose like an ACL tear. We'll see signs of inflammation around the knee, but we're not going to be able to have the fidelity necessary to make that diagnosis on our scan. Integumentary conditions like skin diseases, inflammation of the skin. Let's make sure that you're doing your physical skin examination. A lot of people get the idea that our whole body scan is actually a picture of their body. There's no actual skin imaging being done with us. So something would have to be quite large on the skin for us to be able to detect it. Neurovascular diseases like peripheral vascular disease, plaque diseases, peripheral nerve diseases like ALS, carpal tunnel. Those are not things that our scan is going to be really able to comment on. Breast masses less than 1 centimeter in size. So I talked about 5 millimeters. That's sort of where our current scan is, but we quote about 1 centimeter to our patients because we don't want anyone who's got a mass that large to come to Prenuvo instead of getting a dedicated MRI or breast scan or ultrasound. And then all these other conditions here, coronary artery disease, thyroid nodules less than 1 centimeter, pulmonary diseases like asthma or COPD. These are just a few of the big things that we are just not able to detect on an MRI without contrast. I would encourage anyone on your team that if you're looking for a specific condition, reach out to us and we can give you that advice if that's something that our scan will be able to detect or not. But we've listed on our website a big list of those conditions that are detectable. So again, I would encourage people to refer to our website, type in the condition. If it doesn't show up on our list of conditions, it's probably something you should get a dedicated scan for. And then we're big advocates for USPSTF guidelines. So again, we put this on every kind of patient's report and recommendations. Please adhere to these recommendations and guidelines. We are not hoping to replace any of these things at this point. And then safety-based precautions. These are just some basics for getting into an MRI. We don't manage pregnant patients. Anyone with foreign body metals in their body, we have to kind of do an evaluation to make sure it's a surgical implant that's safe for MRI. Most of them nowadays are, but occasionally you'll find something that's not. We don't manage any patients with pacemakers or implantable defibrillators. We don't have doctors in every clinic. We don't have really access to emergency services there in the clinics. So if something happens to someone's defibrillator or pacemaker, our only option is to send them to the ER. So again, that's something that we don't, even though most pacemakers, defibrillators are probably safe for the MRI, if there's any movement because of the magnet, we are not equipped to handle those. So we actually are saying, as a policy, we don't manage patients with those conditions. Glucose monitor should be removed. Patients under the age of 18, so that's a pretty hard rule for us, as we're not doing any pediatric scans. And then anyone who has a high suspicion of pathology, we're going to just defer them for a dedicated imaging test. So something that you're going to encounter now is that when patients come to us and they have listed in their reason for visit, I want to get a look at my my breast cancer, or I want to get a look at my brain tumor, I want to get a look at my aneurysm. We're going to catch those and screen them, and we're going to actually say, hey, let's get a little more information from this patient. So that's what we call the provider-assisted pathway. That's going to be us pushing back to the patient and the provider saying, hey, please give us a little more context for this condition. The world of radiology, as much as we'd like it to be sort of black and white, we just see what we see and we don't see what we don't see easy, context matters. That if our radiologists sort of know what they're looking for, then it gives them a better opportunity to kind of really capture and comment on the things that the patients want to see. So we actually do have a little bit of intra-scan operability there. But realistically, if there's something that's really high risk or something that really just doesn't fall within our guidelines of what we can capture, this gives us an opportunity to pre-scan, educate the patient and the provider and say, listen, we don't think Prenuvo is the right scan for you. Here are the reasons why. And so that's something that we do as a weekly or twice weekly now committee group. There's about 2 or 3 radiologists. There's a couple of primary care doctors. We sit and look at case by cases that come through this way, and we can help kind of group decide if this is a patient that we can really assist or if we need to defer that patient. So that's like a new process that we've installed over the last year. It's been incredibly successful of helping to kind of counsel patients before their scan and make sure that they're getting the right type of test for their condition that they're looking for. And we look to the providers referring them for help with that, because we want to make sure that we're doing the right thing by you. We don't want to set false expectations of what you're looking for either. So finally here, we kind of land on that patient and provider experience. Again, I think I quoted some of these numbers before. There's over 1,000 patients all getting the NP review, the greeting at the center. All these things are vertical for us. We've got an incredibly strong group of radiologists now, over 600 years of collective medical training, all board certified radiologists domestically. This is all US based. And then our MDs and NPs, we've got about 40 of those folks now working with us who are delivering these high-end consultations at the end of these visits. Here's what one of our MRI reports looks like. So when you get a copy of your patient's report, you're going to see up here sort of the discussion section, which kind of lists all the different limitations of the study. So we talk about all of our limitations there at the beginning. You're going to get the second page is going to be the final impression. So we put all the major impressions up top in the final impression section. And then the next 20 or so pages are going to be the breakdown of every single section. So we start with the brain, we go to the sinuses. Ultimately here, like in this picture, you're seeing the musculoskeletal with shoulders and pelvis and hips. So this is a nice system by system breakdown. This matches what the patient sees in their app. When they go to the Prenuvo app, they're going to be able to scroll through section by section, respiratory, neurological, and they're going to see the same thing here that we've written out for you in written form. You'll notice here, I want to zoom in just a little bit if I can. Maybe I can. But what you'll see here is that the language that we use is quite simple language, that we're really not trying to manage or over prescribe our findings here. We're not giving everyone granular measurements of every single section, because that would frankly take our radiologists far too long to actually deliver a reasonable report. So what we're saying here is sort of like, here's the basic assessment of the knees, here's the basic assessment of the ankles. And then if there is any kind of specific pathology identified, you'll start to get a lot more specific details around that pathology. So we'll start to measure disc herniation, we'll start to measure aneurysms. We'll give precise measurements when there's pathology, but for non-pathological, we're probably just not going to give you an assessment, a measurement. We're going to give you an overall review of that area looking safe or stable. So like, this is a good example here of like a mucus retention cyst that was identified in the body scan. And then we did measure it out. We said, okay, that lesion measures 2.8 by 0.9 centimeters. Metal artifact in the adjacent oral cavity limits the images in that area. So this is sort of the language that we use because that's very simple for the patients to understand, but it also cuts through the noise of what you're trying to find as the provider. That I think that these tests can often get overcomplicated with too much detail. And I think we've walked the fine line here of too much detail versus enough detail, at least enough to take those next plausible steps. The last thing I like to note here is that even though we're giving this sort of simplified report to you and to your patient, you still have possession of all the DICOM images. So every single patient that comes to us will receive a copy or a link to their DICOM images, which is the full sequence of images, all 800 megabytes or whatever it is. We'll put it on a CD or a USB drive for them. There's always a link on their Prenuvo portal to actually touch the link and download it on any time. So patients will always have access to their images, their full sequence, and you by turn will have that same access. Here's what our app looks like, a very slick looking app. We've got beautiful 3D images. People can scroll through the video JPEGs of their different sections of the body. And so again, it's just a really nice way of pocket carrying around your MRI results. And then the third tab there is your PDF of the physician report. And that's the one that probably breaks down a little bit more about what the recommendations are about individual findings. So the place I want to wrap up with you folks is sort of like what comes next. So once a patient gets a Prenuvo scan, what happens? Most of the time, patients are getting access to primary care is the major one. That as much as we're able to review in half an hour with them what we found in the scan and what their next steps may want to be, we really want patients to take these back now to their primary care doctor, look at those final impressions and the summary of their consultation with us, and start figuring out what those next steps need to be. So access to primary care is incredibly vital. We actually recommend every patient who comes through our scan gets set up with a primary care if they don't already have one. We also look for specialist care. So again, if we see something that looks really high risk for any particular area, we'll start to make those recommendations of maybe consulting a cardiologist or a gynecologist next. So having access to specialist care usually starts with primary care. Follow-up diagnostics. Occasionally we'll see a recommendation in our scans for, hey, think about a 6-month ultrasound or a 12-month CT scan. So you'll see some of those recommendations scattered throughout people's reports. And then potential access to immediate treatment. Again, that's the 1 in 20 who we say, hey, we actually found something really urgent. We found something really important. We really want you to go get treatment like immediately. So the last few things we'll look at here is just sort of some case studies. I think this really helps sort of demonstrate what it is that we're doing with our whole body scans. This first case is a 42-year-old patient, actually a physician, who came to us for a whole body MRI screening. The patient's medical history includes a history of pre-diabetes with A1C 5.9 that was untreated, no medicines, just sort of like looking at it, and then high cholesterol managed with their daily statin medication. Family history is significant for diabetes, heart disease, liver disease. So we've got some real risk factors there. And patient puts on their medical intake form, essentially they've followed the Mediterranean diet, but they are still eating fast food a couple of times a week, 3 to 5 alcoholic beverages per week, and about 30 minutes of cardio 3 to 4 times a week. So we get these really nice parts of medical intake forms that tell us a lot more about their social and lifestyle risk factors. So what we see here on the imaging is what their liver is going to look like. So what we'll see here at the top is the level of the liver shows prominent signal loss or darkening of the liver compared to the corresponding in phase at the bottom. So the top is the pathological liver. And essentially this is showing significant steatohepatitis. This is what a healthy liver looks like down here. This is what this patient's liver looked like when we did his scan. It's a significant amount of fatty liver dispersed throughout. So again, what we've diagnosed here is moderate to severe fatty liver disease consistent with metabolic dysfunction. We ended up putting a recommendation out to the primary care to assess this with follow-up studies, including a fiber scan. And then the patient's physician took this and said, let's run with this. We're now going to recommend starting this patient on a semaglutide injection. The GLP-1 got started. They advanced about 1 milligram weekly dose. They continued their cardio, but then added muscle training, strength training exercises. And then they made a more sustainable way of managing the Mediterranean diet. They started using food delivery services, which I thought was really clever, is that this physician, very busy, was receiving now meal delivery to their office for their clinic, and then also getting some meal delivery at home, which really helped them control their Mediterranean nutrition plan so they weren't deviating out with their fast food tendencies. So we actually caught up with this patient about 6 months later, with their follow-up from their primary care doctor, and we saw significant improvements across the board. The patient's A1C, I think, dropped from 5.9 to 5.4. Their triglyceride levels dropped from the 300s down to the 100s. And then their liver function tests sort of remained stable. Something I didn't mention, this patient's liver enzymes were totally normal on that fatty liver period. So when we first saw the fatty liver, we looked at the transaminases and they were all within normal ranges. Then we did the repeat study with them, and their liver enzymes did improve slightly within that normal range, but really that wasn't the major marker for this patient. We had to see the pictures, and ultimately the FibroScan is what showed us improvement of their fatty liver. This one is prostate cancer. So we had a 70-year-old patient come in asymptomatically, underwent whole body MRI to start looking for health issues. And the PSA was about 3.6 at the time of this testing. So that's within normal range for most people familiar with PSAs. Now, what we discovered here was a 2.2 centimeter lesion detected on the left side of the prostate gland. So that's what we see here, about 2.2 centimeter hyperintense lesion. So our advanced MRI technique was used to identify restricted diffusion. So that's that diffusion weighted imaging I talked about, DWI, increasing specificity suggestive of a cancer. So now with a PSA of 3.6 and no symptoms, well, controlled symptoms, I'll say, regarding BPH symptoms, we actually got this patient a more focused follow-up study. So ultimately, the patient detected what we call a PI-RADS5 lesion. This was an ONCO-RADS5. It equated to a PI-RADS5. And that was properly confirmed with a targeted biopsy and then ultimately prostatectomy. So despite having undergone a standard PSA screening testing, our test was actually a higher sensitivity for detecting that patient's prostate cancer. Again, this was something that ultimately could have become metastatic at PI-RADS5. So the patient and we were very grateful that we were able to catch this early. This condition is Graves' disease. So another kind of common thyroid condition. 32-year-old patient with a history of Graves presented for routine surveillance. So this is like they're just coming in for the routine checks, and we happen to see their thyroid at the same time. And so her medical intake form noted nonspecific symptoms like palpitations, insomnia, anxiety, sensitivity to warm environments, mild tremor. And so compared to her previous scan, we're now seeing diffusely enlarged and swollen thyroid gland. So you can sort of see here the visual differences between the thyroid there in 2023, and then here's the thyroid gland in 2024. So we saw this interval kind of heterogeneous tissue, and that gave us suspicion that there's some kind of pathology happening. So this patient ultimately ended up getting a set of blood work done, ultimately a biopsy that confirmed Graves' disease, hyperthyroidism. And so there was no evidence, again, on this patient's Graves that they were having any eye symptoms. There were no complications with like exophthalmos. So again, we're sort of detecting this thing far before the major symptoms could occur. So on follow-up, we identified these changes with kind of ongoing context of symptoms, and then recommended the patient do this follow-up endocrinology workup. So again, what we're able to see here is coronal reformations of whole body diffusion weighted imaging, so the DWI sequence on the left side. And then we sort of see how that evolved in the following scan. And that's, again, how we were able to kind of detect this person's Graves' disease before they were able to get the blood work that ultimately confirmed the diagnosis.